Okay, so we are discussing TB. So TB affects not only the respiratory system, it can go also to other organs. For example, you have got to the brain TB meningitis, to the GUT, genitourinary TB, to the lymph nodes we have got TB lymphadenitis, you have got to the bones and the joints, you are going to have Pott's disease when you are affecting the vertebral column. You have got miliary TB, which is disseminated TB, like it's throughout the body. And then you have got the pulmonary TB that is just to the respiratory system. The causes of TB is Mycobacterium complex, where you have got Mycobacterium tuberculosis, Mycobacterium bovis, Mycobacterium africanum, and then you have got the BCG strains. These strains are actually the ones that we use in the vaccine. So there is a TB vaccine which contains this same BCG. So TB is a communicable disease, meaning that it can move from one person to another. It's actually not acute. It is a chronic inflammatory granulomatous disease. You know that in acute inflammation, you have got neutrophils being involved, and in chronic inflammation the feature is that there is formation of a granuloma. So TB being a chronic disease, there is the formation of a granuloma, and this is caused by Mycobacterium tuberculosis. Now this tuberculosis usually involves the lungs. Why the lungs very much? Because this guy, this bacteria loves a lot the oxygen. It's actually a aerophilic, and the lungs, that's why you have got a lot of oxygen, so that's why it's going to be. It can of course affect other organs, but that's why it's much more common that side. One thing you need to know is that there is there are some other conditions that present with like TB, for example sarcoidosis. But the difference is that the granuloma caused by TB is caseating. So there is caseous necrosis. But for sarcoidosis, even when the features are going to be the same as TB, the only difference is that for the granuloma is going to be non-caseating. So it's important for you to know that. So we have said that TB is a strict aerobe, and it is also acid fast. Why is it acid fast? Because it has got mycolic acid in the cell wall. So it doesn't stain with these gram stains. Instead, it stains with the acid fast stains. So this is how it looks like. It has got a waxy cell wall from mycolic acid that makes it to be acid fast, and it needs oxygen to be able to survive. So it's a strict aerobe. The characteristics that you need to know about TB on the structure is that it has got a mycolic acid lipid layer, which will cover the peptidoglycan, and then it has no spores, it's slowly growing, and it's a strict aerobe. Okay, it will multiply inside the cell intracellularly. It is not stained by gram stain because it has got mycolic acid. So instead, when you want to stain this one, you use another stain which is known as the Nissen stain, the ZN stain. It's a very important stain for us to know. So cell-mediated immunity, instead of antigen, antibody produces the delayed hypersensitivity reaction when you have got this. So when TB comes in, the TB is going to be fought by the T cells. So you not from this antigen antibody reaction, but you have got the cell mediated immunity that is via the T cells. The staining, we've said that you use a ZN stain. ZN stain is also known as the acid fast bacilli, AFB. There is an exam where they just said, what does AFB stand for? Or one paper I was going through was saying, what does AAFB stand for? So for the AAFB is alcohol and acid fast bacilli. That's the same as the ZN stain. That is because of the mycolic acid. So elongated bacilli stain with ZN stain because it's acid fast bacilli that resists the discoloration by alcohol. So not stain by gram stain because of the mycolic acid. For you to have TB, there are some other factors that you need because majority of us we are actually exposed to TB, but we only have the infection, but we don't have the disease. In other words, the bacteria is inside us, but we have no symptoms for the sickness. Why is that? Because we are not immunocompromised. So some factors that predispose someone to having TB includes poverty, crowding, malnutrition, and chronic debilitating illness. If you have got a chronic illness, that weakens the immune system also. So these are predisposing factors. And people that have got are at an increased risk of getting TB includes people with HIV and AIDS, especially people that have got diabetes mellitus, Hodgkin's lymphoma, the alcoholism, those that have got chronic lung diseases like for example silicosis, and those that have got let's say they are taking immunosuppressive therapy, so those are also going to be at an increased risk of getting TB. What causes TB is the Mycobacterium complex. You have got Mycobacterium hominis. This one is specifically for human and it is transmitted via the droplets when someone is breathing, coughing, and then or sneezing. So you also have the Mycobacterium bovis. This one is specifically in the cows, and it is transmitted through unpasteurized milk, and then it will go to the lymph nodes. So take note, unpasteurized milk. So someone just going direct, they a, on a cow, they start drinking the milk. There's a problem there because this M. bovis will actually be able to cause intestinal TB. And then you have got Mycobacterium avium. This one is atypical. It is only in the immunocompromised. And if you have got the Mycobacterium avium complex, we call it MAC. So here there is no granuloma formation. So for the MAC, there are actually different types of or strains of Mycobacterium. You have got Mycobacterium avium, Mycobacterium intracellularia, and then Mycobacterium chimera. We've talked about the risk factors that predispose someone to having TB, HIV positive patients, recent immigrants within the past 5 years. Like you go to an area, let's say where a lot of people have got the infection. The prisoners also because of overcrowding, and you know this condition is spread via breathing. The healthcare workers, close contact of someone with TB, alcoholics, diabetes, glucocorticoid or immunosuppressive suppressant use, hematological malignancy, injection drug users. So when you are clicking a case and someone has got, you are suspecting that someone has got TB. When you look at the features first that they have, you ask them what brought you to the hospital. Okay, they tell you, I've experienced this weight loss, I've been having a cough, and then also feeling just tiredness. The cough is also productive. Now, the cough here can start as non productive, it can start as dry, and then it can become productive with some sputum that is like yellowish green. They've told you all these things. You want to click more to find out really what's wrong. So you want to find out about do they have risk factors? So you in the past medical history, you are going to ask them about the HIV status. If they've tested for HIV, are they positive? You are in the travel history, you are going to ask them if they've traveled to some area far within the past 5 years. If they've been, but you can of course ask if they've been in these overcrowded places like the prisons. Boarding schools are also overcrowded, right? Healthcare workers, because they're in the hospital where there are a lot of people that have got TB, so they are also very much exposed. If they've got someone with close contact, I mean someone that has got TB who is their close contact, if they drink alcohol, they have got diabetes, or they are taking any drugs to lower immunosuppressant. For example, if they have got any, what condition can I give? Let's say inflammatory condition like rheumatoid arthritis, systemic lupus erythematosus. But you not ask them if they've got systemic lupus erythematosus because probably they don't even know themselves. So that's where you need to know now the features of the condition itself. If they've got a Mara rash, if they've got uh, some, these lesions when you look at the mouth, you also, there is also some problems with the urinary system. Okay, systemic lupus affects nearly the entire body. Okay, so those are some of the things that you want to ask about. Are you on any drugs? Like for example, someone, if they've got osteoarthritis, you, to find out if they are on glucocorticoid, if they just can't tell you direct, you also look at these conditions. For example, the features, if they've got these small the small joints being stiff, being painful and such. Hematological malignancy, do they have a leukemia, do they have got these lymphomas and such? Are they IV drug users, especially if someone is coming from the, someone from the street of Lusaka, where this thing is what they live on. Probably everyone does it. So, how does TB really happen? So, when you look at TB, it's actually split. You have got three stages of TB. You have got primary TB, you have got the latent TB, and secondary TB. Primary TB is normally asymptomatic. Latent TB is the condition, as like it's just resting. And then you have got the secondary TB, which is now the active TB, caused by either reactivation or reinfection. So when you look at primary TB, how does it happen? First, a person infected by Mycobacterium TB gets, let's say, to cough, and then you have got this bacteria in the atmosphere, and then someone inspires them. They end up going to the lungs, and then there they'll meet the alveolar macrophages, the dust cells. And then when these macrophages take them up, so these guys, the Mycobacterium tuberculosis is now inside the macrophages. Inside the macrophages, you have got a receptor which is known as the macrophage mannose receptor. So these guys bind with a molecule on the bacteria which is known as the mannose capped glycolipid. And so the macrophage will recognize the bacteria and then start So before the actual phagocytosis, before this bacteria even goes inside the phagocyte, the first thing is there is interaction between the mannose receptor on the macrophage and then the mannose capped glycolipid, and then phagocytosis will start. Bacteria, once the TB, the Mycobacterium tuberculosis bacteria has been phagocytosed, what it does is that it releases what is known as the code factor. Now, the code factor, because when something has been phagocytosed, what happens is that that phagosome is supposed to fuse with a lysosome to form the phagolysosome that is now going to be broken down. But then for TB, it will release the code factor, which will prevent the fusion of the lysosome with the phagosome. And so what happens is that the bacteria will not be destroyed inside the macrophages. And so it will start to proliferate, to multiply like that. And then, like after 3 weeks, it is now going to end up going to the lymphatic tissue or the lymph nodes. So there, the antigen presenting cells will now present the antigen through the MHC class 2 to the T cells. So the antigen presenting cells, the macrophages will end up now getting this bacteria and then take it to the T cells. So that will lead to the activation of the T helper 1. And when you activate the T helper 1, because of the bacteria that you are presenting, they release chemokines and interferon gamma. And these guys, the interferon gamma and the chemokines, will activate other macrophages. The activated macrophages will become large. They have got a lot of nitric oxide free radicals. So this nitric oxide and free radicals will end up now killing the bacteria and then release the tumor necrosis factor. Tumor necrosis factor, again, it will increase the recruitment of the monocytes. You know, it's from the monocyte that macrophages come from. Okay, so you have got a lot of other macrophages that are coming in, and all these cells, so you have got dead bacteria, you have got live bacteria, you have got all these macrophages, and that is what forms a granuloma. You can see this is the bacteria, and then you have got the alveolar macrophage. You can see the macrophage mannose receptor, and then the mannose capsid glycopeptide, and then there's going to be phagocytosis. After the phagocytosis happens inside the alveolar macrophage, we said that the bacteria is producing the code factor preventing the fusion of the phagosome with the lysosome. At this point, the alveolar macrophage is going to present the bacteria to the T cells via MHC class 2. On the T cells, you have got the T cell receptor. Okay. And then the T cell, then you can see these guys activated into the T helper 1. And the T helper 1, it is this guy which was going to be responsible for the tuberculin positive test or the hypersensitivity that happens. This is the delayed hypersensitivity. You know, in delayed hypersensitivity, you have got this is cell mediated hypersensitivity because of the T cells. And then this T helper 1 will produce interferon gamma. Interferon gamma will activate the macrophage, that same macrophage that presented the parasite, the bacteria to the T cell. Once activated, macrophage will produce the nitric oxide, and then you're also producing things like the free radicals. These guys will now end up destroying bacteria. And then you also have the chemokines being produced and the other tumor necrosis factor, which will recruit other cells, the monocytes. And then you have got the formation of a granuloma because you have got a center that has got dead cells, which or caseous necrosis, and then you have got the T cells around, you have got the macrophages and everything. So that's how you end up forming a granuloma. I hope that is okay. That just makes sense of how it is happening. So if I'm asked, why is it that the bacteria is not killed when phagocytosed? It releases something. What does it release that prevents the fusion? It's a code factor. So primary TB, the patient has no previous infection. This is the first time someone has gotten the TB, Mycobacterium tuberculosis. And then the pathogenesis is because of inhalation of these bacilli. So there's going to be phagocytosis. Lymph nodes are going to end up calcifying, and then they'll produce what is known as a gone focus. We'll talk about it. On the microscope, you are going to see granuloma. And then what site is affected? So the part of the lung that is affected is either the upper part of the lower lobe or the lower part of the upper lobe or the middle lobe. You know, the middle lobe is going to be on the right line, isn't it? So upper part of the lower lobe or lower part of the upper lobe. Clinically, someone is going to be asymptomatic, or they can have flu-like symptoms in a few cases. It can, primary TB can also end up affecting other organs. Okay, spreading from the lungs. That's known as non-pulmonary TB, also known as extra pulmonary TB. Now, extrapulmonary TB is TB outside the lungs. For example, if someone has got GI TB, it is extrapulmonary. If they've got, let's say, TB meningitis without having respiratory TB, that is extrapulmonary. You also have what we call disseminated TB. Disseminated TB is involving a lot of organs at the same time, including the respiratory system. Disseminated TB is also known as miliary TB. So differentiate extrapulmonary TB from disseminated TB. Extrapulmonary just means that it's not involving the pulmonary, only other organs. So what are the clinical features on history? What are you going to be asking? So you have asked the patient when you are taking your chief complaint, okay, sir or madam, what brought you to the hospital? They tell you, have been having night sweats, fever, weight loss, fatigue. And remember, when you are taking history of the chief complaint, the HPI, you are going to try to break down, really expand more on what the patient is saying. But don't use medical terms. For example, do you have PND? You are trying to mean, do you wake up at night to catch a breath? Don't use that language. So make it plain. Do you wake up at night to catch a breath? Orthopnea, do you use maybe pillows when you are sleeping so that you breathe well? So even when you are writing the report or the history, in the HPI, don't put PND there or orthopnea. Make sure you use that language that is layman. The patient to present with these constitutional symptoms, okay, fever, night sweats, weight loss, fatigue. But they also have pruritic chest pain. What is pruritic chest pain? This is the chest pain that someone is going to experience when, let's say, for example, they're applying some pressure on themselves, like during coughing or when they're making these maneuvers. So that's pruritic chest pain, worsened by coughing. There's also a chronic cough, anorexia. Someone doesn't want to eat, they end up losing weight, and then there's also erythema nodosum. Those are symptoms. For the signs, often someone will not have signs. When you do your auscultation, your percussion, your palpation, they probably might be normal, okay, or with all those. So majority is just on the taking of the history, not the physical exam. There's going to be involvement of the mediastinal lymph nodes, specifically the hilar lymph nodes. You know, for the lungs, the trachea has got a point where it bifurcates into the primary bronchus, the left and the right primary bronchus. So the lymph nodes found on that point of bifurcation are the hilar lymph nodes, and these are going to be involved. And then there can also be pleural effusion. Pleural effusion is where someone has got fluid in the pleural space. Okay. This fluid can either be blood, it's known as hemothorax. It can be pus, epaema, or empyema. It can also be lymph, chylothorax. So that is a pleural effusion. Lung infiltrates may be seen and involve lower lungs or middle lung field, most common with possible cavitation in areas of consolidation. So there is a consolidation, like there is a mass. There is a certain mass, and then there are some cavitations there. When you are percussing, you need to know the features of percussion or auscultation for a consolidation like a mass. Okay. For a mass, as you try to percuss a mass, like this is a solid, what are you trying to expect in that case? You also have the non-pulmonary or extrapulmonary TB. You have got TB of the lymph nodes, that's known as TB lymphadenitis. And then you have got TB of the vertebral column, these bones and the vertebral column. We call that as Pott's disease. So it will present with someone having back pain and paraplegia. So they have got this weakness on the lower limb, bilateral weakness of the lower limb. So you should differentiate it again from an effect that is, let's say maybe someone has got weakness of the limbs because there's just a problem with the brain. How do you differentiate the spinal injury from brain injury? The spinal cord controls reflexes like, for example, urination, defecation. So I also want to ask them about urinary incontinence. That becomes important if someone has got a spinal injury, and also problems with defecation. Okay. You also have brain TB, which is TB meningitis, probably one of the worst. So how TB meningitis presents is, someone is going to have encephalitis, to present confusions. They can have also a tuberculoma. So TB can either form a tuberculoma in the brain or an abscess in the brain. So take note of those two. Someone is going to have headache and these neurological deficits. So meningitis has got a triad. So you'll be able to see that triad of this headache and the other features. Pleura can also be affected, like tuberculosis pluris. So there can be pleural effusion, specifically something that is going to be exudate because TB is an infection. We'll discuss pleural effusion. Is one of the high yield topics in pulmonary that we need to know. Exudate pleural effusion means that there is actually proteins, okay, or not really proteins, but there are cells in this fluid that is accumulating in the pleural cavity. You also have GI TB, specifically affecting the ileocecal region. Take note of that for the sake of an MCQ. And then GUT, the renal TB. Miliary TB is also referred to as tertiary TB because affects the entire body. So when TB starts, like the primary TB, okay, you're having the formation of a granuloma. This granuloma that you form is known as a, so I've got what we call a gone complex. Now gone complex has got a gone focus or gone lesion with the involvement of the hilar lymph nodes. So what is a gone lesion? So a gone lesion or gone focus is just a granuloma that you are forming, and we said it is in the upper part of the lower lobe, or the lower part of the upper lobe, or the middle lobe in case of the right lung. So that is a gone focus showing caseating necrosis, and it's a feature of primary TB. If the hilar lymph nodes are also involved, like you see lymphadenopathy of the hilar lymph nodes on chest X-ray, that's now known as a gone complex. What is a gone complex? It's a gone focus with the affected hilar lymph nodes. Okay. You also have what we call, so on radiographic findings in primary TB, you have got the gone complex, calcified primary focus with an associated lymph node, and also there's a rank complex. So when the gone complex undergoes fibrosis and calcification, then we call that as a rank complex. Okay. So you can see on chest X-ray, there is the involvement of the hilar lymph nodes. You can see here where there is a red dot there, and then there's also going to be a granuloma. There's another dot here that you can see in red. So those two features shows that someone has got this primary TB. Latent TB implies the presence of small number of this bacterium. So in latent TB, like, you have got the infection, but you don't have the disease. So if you do the tuberculin skin test or the Montauk's test, I don't know how to pronounce that, you are going to have the test being positive because you have got the bacteria. But then the thing is that you don't have the disease. Okay. So the chest X-ray is going to be normal, but the tuberculin test is going to be abnormal. Secondary TB, the problem here is it is either reactivation of the old TB. So someone had primary TB, maybe they got better, they were treated, but then it gets to be reactivated, that is endogenous, or it can be exogenous where you get another infection. That's known as a reinfection. Okay, and it normally happens in immunocompromised people. Lesions are normally going to be located the apex of the lungs. Now, why the apex? Think of this: oxygen is a gas. Gases are not going to be at the base. You are likely going to find them at the top, right? Just as an analysis, something to help you remember, not that that's true. And you know that this guy is very much loves oxygen. So oxygen is going to be more at the apex of the lungs, and so even the lesions are going to be more at the apex because the bacteria itself is aerophilic. I hope that is okay. So clinically, someone has got also the B symptoms. They also have hemoptysis, like they are coughing blood. Okay. They can also be miliary TB, like the TB gets to spread. Actually, miliary TB is more common in secondary TB than in primary TB, where there is involvement of nearly the entire body. It's more common after reactivation or reinfection. You are going to have these cavitations that are going to occur in secondary TB, so that will lead to erosions into and dissemination along airways. So these changes are going to become important for infectivity to happen, like you're having cavities being formed. So TB can be acquired through consumption of unpasteurized dairy products. So that can cause intestinal TB, like someone just goes and they are drinking milk from the cattle direct. You can see this is a granuloma. So what are the symptoms of secondary TB? You have got the constitutional symptoms. You have got cough, which starts as a dry cough and then it will become a productive cough, which is with a sputum that is yellow, greenish, also smelly. So these are the things that you'll be asking. If someone says that they have got cough, ask them, are you producing any sputum or not? They should also tell you the color of the sputum, the amount of the sputum, the smell of the sputum. Okay. In TB, someone is also going to be coughing blood. So don't ask them, do you have hemoptysis? Ask them, do you cough? When you are coughing, do you have blood as you are coughing? Some signs that you are going to be looking at is, remember we said that this involves the apical segments, specifically the apical posterior segment of the upper lobes. Okay. There's also going to be cavitation, involvement of the hilar lymph nodes. So what are the complications of TB, pulmonary TB? There is hemoptysis. There's also a pneumothorax. Pneumothorax is where someone has got air in the pleural cavity. There's also bronchiectasis. It's also one of the common conditions we discuss. This is part of this obstructive pulmonary diseases with COPD. There's also the destruction of the lungs. Miliary TB is just TB that has spread and it is there throughout the body. So, how do you diagnose TB? Okay, how do you diagnose? This is very important because the thing is that majority of the questions that you're going to be having is even after you click, you take the history, you do the physical exam. You're going to be also expected to do what will be the investigations you carry out, all the questions that came in the OSC, the writing questions. For each one of them, you give investigations, and we are mentioning at least three investigations, four investigations, and for TB, it's even very much important the investigation. Okay. So for TB, you can get sputum, and then that sputum, you look at different things. So it's very important to know. But how do you get this sputum? You get three early morning sputum samples, or induced cough, or a bronchial lavage, or gastric washing for the infants. So you this should be very carefully done so that the patient doesn't end up just giving you saliva. It should be sputum. It should be sputum. Okay, and it is a 3 early morning. Bronchoscopy with watching of the affected lobes is going to be useful if no sputum is available. So when you get the sputum, you can do sputum analysis. You are going to stain the sputum using, there is this called orami, oramin fluorescent test. This one is very good. Okay, it is more sensitive. Now, there is a difference between sensitivity and specificity. It is sensitive means that it can pick up mycobacterium species. So meaning that anything that has got the features of mycobacterium, it will pick up. So it might not just be mycobacterium tuberculosis, but something that is specific means that if it is MTB, mycobacterium tuberculosis is only MTB. So that is being specific. So this one is sensitive. The sputum analysis you can also stain using the ZN stain, though the ZN stain is not as sensitive as the Oramine fluorescent test. Remember the ZN stain is also known as the AAFB, the alcohol and acid fast bacilli. And then on the sputum you can also do culture. Culture is a gold standard for diagnosis of TB. And culture is used for both identification and sensitivity. The media that we use for culture is the Lowenstein Jensen media, the LJ media. But the problem, there isn't, even when culture is a gold standard, it's not normally done because it takes a lot of time, like usually 4 to 8 weeks, like 1 month to 2 months. That's long. If you use a liquid culture, the time becomes a bit lower, up to like 2 to 3 weeks. And then to test for sensitivity, sensitivity testing takes like a further 3 to 4 weeks. So culture takes a lot of time. On the same sputum, you can also do PCR, polymerase chain reaction, to detect the bacterial DNA. Now, specifically, what we do is known as gene expert. Very important, and this is the most common at UTH. If you get a sputum, you send it for gene expert. Urine can also be sent for gene expert. So gene expert is just a molecular diagnostic test, and the goodness is that it does two things. It will be able to detect the DNA. Please, it doesn't detect the antigen of the bacteria, neither does it detect antibodies to the bacteria. It detects the nucleic acid, because this one is a nucleic acid amplification test. So it will detect the DNA or the RNA of the bacteria. Now, besides that, it also tests for sensitivity of one of the important drugs that you use for the treatment of TB, the drug known as rifampicin. Okay, so that is very important to know that Gene Expert, not only is it used for diagnosis of TB, but also to test if there's resistance to rifampicin. Okay, so if there's resistance, it means that already the drug wouldn't be important when it comes to treatment. And then another uh, investigation we can carry out is to diagnose, if you are trying to diagnose extrapulmonary TB, like TB that is involving other organs, what can you do? This one normally depends on a high index of clinical suspicion. You are really suspecting this is really TB. Okay, this is really TB. So recovery of the organism from specimen is still necessary when possible. Like you get a specimen for the organ that you are thinking is involved. For example, a lymph node biopsy, like in TB lymphadenitis, bone marrow biopsy, also urinary testing or aspiration of pericardial fluid. You can also do lumbar puncture and cerebrospinal fluid examination for evidence of TB infection. Okay. And this is, so a lumbar puncture should be done in all forms of miliary TB. Miliary TB is where the infection has spread throughout the body. Someone has got features of miliary TB, like the uh, involvement of different parts of the body, and we suspect this is TB, always do a lumbar puncture. And HIV testing should also be considered, because if someone has got TB, you are thinking by the time they're having this, there should be some condition. Maybe they're immunocompromised, and majority of them actually have got HIV. Besides that, it's also important for you just to know that the HIV status, so that you also know how you'll be able to treat well. Okay, you can also do a chest X-ray for primary TB. So on chest X-ray, what are you going to see? A question in the exam they can describe to say a patient comes with, let's say, with productive cough and night sweats, the other base symptoms, and then on next chest X-ray they show patchy or nodular shadow in the upper zone with low volume, fibrosis, or without cavitation. At least take note of this patchy or nodular shadow. These two small things that you can see, like dots. So we call this as a miliary picture. Now, for the miliary picture, you need to know other differentials. So, for primary TB, what you are going to see is this: you are going to see lateral lesion and hilar lymph nodes. You are going to see what we call the Gon complex. Okay, lateral lesion somewhere here, and then you also see the involvement of the hilar lymph nodes. For secondary TB, there's apical lesion. We already mentioned that. For miliary TB, there is these multiple lesions. Okay, we call them the miliary shadow, like 1 to 2 millimeters in diameter through the lung. These are the ones that you can see, these dots that you can see here. That's known as the miliary picture. So there are a lot of differentials for the miliary picture, and you need to know them. So you have got infectious causes of miliary picture and the non-infectious causes. So you divide them like that, and then when you look at the infectious causes, again you split them into those caused by viruses, for example, the CMV cytomegalovirus, those caused by fungi like histoplasmosis. Okay, you have got aspergillosis. You have got those that are caused by bacteria, for example, the same TB. You also have the non-infectious causes like sarcoidosis, amyloidosis. You have got hemochromatosis. So you should be able to give at least 10 differentials for the miliary picture. There are a lot. Please look them up. You can also do the Mantox or the tuberculin skin test. So for the tuberculin skin test, this one, what you basically do is you get to the subcutaneous injection of like the dead bacteria to the skin, and then you are going to see the area of induration, like the area that has swollen. You measure the size, but you don't look at, because when you do that injection, the surrounding skin is going to be red. You don't consider the red skin or the erythema. You only look at the area that is swollen. Okay, the thing is that this Mantox skin test is going to be positive even when someone does not have the disease. Okay, if they just have the infection, or if someone was previously vaccinated, because it is also in the vaccine is also made up of like the TB. So someone that is vaccinated will still be positive for this test, but they don't have the infection. So that is why it is not really good. So the prognosis of TB is good if infection are localized to the lungs and then there's proper treatment. But the prognosis, like after treatment, is someone going to recover well? Is very bad, especially if someone has got if infection are by drug resistant strains, or it occurs in aged, debilitated, or immunosuppressed persons. So it becomes very bad. And how do you treat TB in conclusion? You treat it for 6 months. There are first line drugs and second line drugs. So the first line drugs, these ones kill the bacteria. They are bactericidal. You have got four main ones: isoniazid, rifampicin, pyrazinamide, and ethambutol. You need to know these four. Streptomycin is also part of them, but it's not commonly used. Okay, if they ask you about the first four, the many drugs, it's these four: isoniazid, rifampicin, pyrazinamide, and ethambutol. Second line, these guys you only give them when the first line has failed or when there is contraindication to first line, and they're also used in typical and atypical TB. The thing is that they've got a lot of side effects, and these ones are not really bactericidal but bacteriostatic. So they include drugs like the fluoroquinolone, ciprofloxacin, levofloxacin, moxifloxacin. You have got the oral anti-TB drugs like kanamycin, amikacin. You have got rifabutin. Rifabutin can actually substitute rifampicin when you are treating someone that has got TB and then they have got HIV. The thing is that rifampicin is a liver enzyme inducer. So it will cause, when you are treating someone for TB and HIV at the same time, rifampicin will induce the liver enzyme and then they'll start breaking down the HIV drugs. So it means that the effect will be bad. Like you are taking the drug, but then there's no effect. So in that case, you can actually give rifabutin. You also have these other drugs like the linzolide. Okay, so these are the second line. It's very important for you to take note of the side effects of these TB drugs. Very, very important. Rifampicin, actually, all the TB drugs are hepatotoxic. They are injurious to the liver. Rifampicin, again, will change the secretions, body secretion orange. It also Rifampicin is also a cytochrome or liver enzyme inducer. And then isoniazid, the important thing, the biggest problem here is that it causes peripheral neuropathy. How it does that is that it depletes vitamin B6, pyridoxine. That is why when you are giving, if someone is on TB treatment, you also give them vitamin B6 because it will be depleted, and if it is depleted it will causes peripheral neuropathy, like problems with the nervous system. Besides that, isoniazid is also a liver enzyme, not inducer but inhibitor, and it is also going to cause agranulocytosis, a reduction in, actually the increase in the agranulocytes. Pyrazinamide, the big problem here is that it causes arthralgia and myalgia. Okay, bone pain, and also muscle pain. It also causes hyperuricemia to increase uric acid. And so this is like, if there's high levels of uric acid, it's more like precipitating someone that has got, let's say, a condition like osteoarthritis or gout. It is worsening that. In Thambutol, you need to know about this one. In Thambutol, think of E with eyes. So it affects the eyes. It will cause optic neuritis. I actually don't give Ethambutol in children because when you are giving these drugs, you're actually going to tell your patient, as you start taking these drugs, if you notice that you are having some difficulties or problems in seeing, you should come and report quickly. But the reason as to why I don't want to give Ethambutol in children is that those that are less than 5 years is that when they start having this problem with sight, they can't report that I've got a problem with sight. So in such a case is that they can actually just go into permanent loss of eyesight. Okay, so that is a problem with that one. So you don't want to give it. So Ethambutol causes a red green color blindness, optic neuritis. So there is need for testing of visual acuity using the Slanage chart and also the red green color perception. Okay, should also be tested. So please take note of the many side effects: pyrazinamide, hyperuricemia, and gout, the arthralgia, myositis, isoniazid. The biggest problem here is the vitamin B6 depletion, rifampicin liver enzyme inducer. Okay, so the thing is that since all these drugs we have said that they cause problems with the liver, right? Like they lead to destruction of the liver. When you just see that there is elevation of the liver enzymes, you don't stop giving these drugs. Not until you see that really there is just a problem. Okay, like there is obvious signs that the liver is now going into destruction, not just elevation of liver enzymes. So if the liver enzymes, like you see, like the liver transferases are increasing, you don't just stop the drugs. And the way you give these drugs, so streptomycin, I didn't mention much about it. This one is an aminoglycoside. It's no longer popular because of resistance. Okay. And it just becomes useful in life-threatening condition. The adverse effect for this one is ototoxicity and nephrotoxicity. So points you need to take note is that when you are giving TB treatment, the first 2 months, because remember we said that you treat for 6 months. The first 2 months is known as the initiation phase. Here you give all the four drugs, rifampicin, so you say RIPE, rifampicin, isoniazid, pyrazinamide, and infambutal. And then for the next 4 months, that is the continuation phase, you only give rifampicin and the isoniazid. So a total of 6 months. But for TB meningitis, you extend the treatment to 12 months. And if you have got Port's disease, like the TB of the bone, treatment goes to 9 months. Never forget to give pyridoxine 10 milligrams or the vitamin B6 as you get to treat TB. There's also something called TB iris as we conclude. TB iris stands for immune reconstitution inflammatory syndrome. So what happens is this. So TB iris is a paradoxical, like it just happens without you knowing, like that. So worsening or recurrence of pre-existing TB lesion or development of new lesion in patients on effective anti-TB treatment. It may occur during or even after TB treatment. So what is happening is this. Someone has got HIV, okay? They might have been treated, so probably, so it's either you are treating them for TB or not, but someone has got HIV. Let's say there is this person that has got HIV, you start treating them for HIV. Now for HIV, the thing is that the CD4 count is low, like the immune system is low. So what happens is that when you start treating them, the CD4 count starts to increase, like the immune system is now getting to go higher. So what happens is that the immune system, if there is any hidden TB, the immune system will now be able to see it because it has now become strong because of the treatment of the HIV. The immune system has been boosted. So it will see any TB that is hidden and then it will start attacking, and then there will be these signs that will be shown. So that is known as unmasking TB. So the TB was hidden, but now it is unmasking, like it is now coming out. So TB symptoms appear for the first time after starting HIV treatment, the ART, antiretroviral therapy. Okay, despite not previously diagnosed. And then there's a second scenario where someone has got TB, right? You are treating them for TB, and then you also start treating them for HIV. When the immune system becomes so good, they were responding well to the TB medications. But because the immune system has become good, the TB symptoms end up worsening. That is known as paradoxical TB iris. Okay, so what are some of the symptoms you see? Fever, lymphadenopathy, worsening of the respiratory systems, new pulmonary infiltrate, pleural effusions, some cases neurological symptoms. Okay, so that is it. So this is again, this is what I'm showing. So you have got a patient whose TB is diagnosed, and then you start treating for HIV. There is improvement in TB disease, but once HIV treatment starts, there is worsening of the TB symptoms. That's known as paradoxical. And then there's a second patient. They are not, you have not diagnosed them with TB, and then they are not on HIV treatment, they are fine. But when you start treating them for HIV, there is now rapidly onset of previously undiagnosed TB. They start showing symptoms of TB, like you can now see the TB. That's known as unmasking. So the paradoxical MTB culture is going to be negative. Okay. Immune response to MTB, there is actually an immune response to the mycobacterium antigen. For the unmasking, the culture is going to be positive. And then there's also immune response to the live TB. But you need to make sure that for you to say this is iris, you need to make sure that in there is initial improvement of TB related symptoms or the radiological findings after treatment with TB, like they are improving, or there is paradoxical deterioration of TB related symptoms or radiological findings at the primary or at new location, like just something just happens, the symptoms start to worsen. And then there should also be absence of condition that reduce the efficacy of anti-TB drugs, because probably why the symptoms of TB are worsening is because of just the TB drugs are not working. For example, there's poor compliance, drug malabsorption syndrome, or drug side effects. You need to make sure that it's not those features. Again, you need to make sure that is there's no other explanation for the symptoms that the person is showing. That's when you are going to say that someone has really actually this TB iris. Okay. So, and in conclusion, for the TB that you are treating, there is also what we call drug resistant TB. There is multi drug resistant TB, we call it MDR-TB, multi drug resistant TB. So multi drug resistant TB means that someone is resistant to isoniazid and rifampicin. So if someone is resistant to isoniazid, rifampicin, and any other drug, as long as these two are there, you call it multi-resistant, multi-drug resistant TB, MDR TB. If someone is resistant to, so someone is resistant to these guys, I, so at least to isoniazid or to rifampicin, and to any fluoroquinolone like ciprofloxacin, you call that as EDRTB, others say XDRTB. That's extensively drug resistant. These ones are resistant to what? They are resistant to, so these ones actually MDRTB plus resistance to fluoroquinolones plus at least liso, linezolid or bedaquiline. So resistant to rifampicin, isoniazid, fluoroquinolones also, and also the linezolid. What causes resistance includes incorrect prescription, irregularly irregular supply of the drug, non-adherence, or low grade quality of the drug. Okay. So if you want to help someone that is taking TB drugs, there is what we call the DOTS, directly observed therapy. So there's going to be a person, the second a person B, either a nurse or a family member that will be with the patient. If they take the TB drug, you tick. They take the TB drug, you tick like that, so that you just help with them being compliant. Okay. So the MDR-TB is resistant to isoniazid and rifampicin. You have got pre-XDR-TB, so there is the additional resistance to the fluoroquinolone besides the isoniazid and rifampicin. And then there's XDR-TB where there is resistant to, so it is MDR-TB resistant to isoniazid and rifampicin. In addition, there's also resistant to fluoroquinolones, linezolid, and or bendaquilin, that is extensively drug resistant. Please take note. Besides the fluoroquinolones, you also have either linezolid alone or bedaquiline alone without the linezolid, or both of them. But there should also be fluoroquinolones and isoniazid and rifampicin resistance. There's also totally drug resistant TB, which is basically resistant to all the first line and all the second line drugs. You can vaccinate someone. There's a BCG vaccine for someone that has got TB, and that can help. Okay, and you want to vaccinate especially people that have at high risk. Some people in the hospital, like the medical practitioners, people in overcrowded places, and such things. So this is it about TB. I hope by now we can be able to click a case nicely, diagnose it, talk about the investigations and also the treatment, and also talk about TB iris.